Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, the Junge Deutsche Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Dr. Marie Evans and Dr. Anne-Laure Faucon in Stockholm, Sweden, with whom we would like to discuss whether and how to anticoagulate patients with advanced chronic kidney disease, CKD, and atrial fibrillation, focusing upon their Swedish SAC study. Dear Marie, dear Anne-Laure, we are glad to have you back at home after our 2025 webinar on epidemiological trends in cardiovascular events and bleeding in advanced CKD, and we are happy to discuss another important cardiorenal issue with you.
Dr. Evans is research team leader and principal investigator at Karolinska Institutet in Stockholm, chair of the Swedish Nephrology Research Network, and principal investigator of the SAC trial and of the Swedish Renal Registry Chronic Kidney Disease, which is National Registry of Nephrology-referred non-dialysis patients integrated in the Swedish Renal Registry. Dr. Faucon is senior nephrologist and epidemiologist at Karolinska Institute. Her main research focus are risk factors and biomarkers of CKD progression and of CKD-related diseases. Before she came to Sweden, she has been post-doctoral researcher at the Department of Clinical Epidemiology at Paris-Saclay. Thank you for joining us again.
Thank you very much.
Yes, so thanks a lot for inviting me to give this presentation on the use of anticoagulation in patients with CKD, and especially focusing then on the later stages where we have limited data so far. And I really hope to give you some input in this matter, but I think that we have to agree that we will be maybe informed and confused on a higher level after this presentation. So first of all, you need to be aware of that CKD patients have a very high thromboembolic event risk. In fact, in this analysis, it was shown that patients with CKD on dialysis have about 4 times higher risk compared to the general population for venous thromboembolic disease. The standard of treatment to prevent thromboembolic disease is especially in patients with atrial fibrillation, is vitamin K antagonists. And these drugs, they act upon several parts of the coagulation system, and they mainly act through inhibiting carboxylation of proteins which are made in the liver. So the reason we use vitamin K antagonists is because it was seen in several large trials in the 1990s that this drug was effective in preventing stroke compared to placebo. And you can see here that these drugs reduce the risk with almost 66% compared to placebo. And these trials also shown that these anticoagulation drugs more effectively reduce the risk as compared to aspirin. But there are several problems with the use of vitamin K antagonists, and especially it is because they have a limited therapeutic window. These drugs actually are associated with a higher risk of events if you have a time in therapeutic range which is not within the treatment target, an INR in between 2 and 3. So if you have a poor INR control, which is regarded as a TTR, time in therapeutic range below 65%, that is associated with a higher risk of stroke and systemic embolism, and also a higher risk of bleeding. So patients on dialysis, they have a lower TTR. And you can see from this Swedish publication that CKD stage 5 patients especially have a lower risk on time in therapeutic range. And this risk declines with eGFR. There are also several other problems with vitamin K antagonists in dialysis patients. To the left, you can see that patients on dialysis have more than 50 times increased risk of major bleeding as compared to patients with a normal kidney function. And you can also see that they have an increased risk of calcifications in their vessels, and especially this dreaded complication of calciphylaxis has been associated with the use of vitamin K antagonists. Then, a number of years ago, the direct oral anticoagulation drugs came on the market. And as opposed to the vitamin K antagonists, these drugs, they act specifically on two parts of the anticoagulation of the coagulation system. So first of all, you have the thrombin inhibitors, and then you have the factor Xa inhibitors. And these drugs are the bigatran, which inhibit thrombin, and you have apixaban, rivaroxaban, and edoxaban, which are factor Xa inhibitors. In comparison with the vitamin K antagonists, you can sort of see these drugs as a steam engine as compared to a brand new BMW. So you have, first of all, the vitamin K antagonists. They have a very slow onset, and they also have a very slow offset when you deprescribe the drug, as compared to the DOACs, which directly inhibit the coagulation system. They have a direct onset, and they also, their effect also rapidly decrease when you discontinue the drug. These drugs, the four different types of DOACs, they have a different renal elimination. And you can see to the very left that the bigatran or Pradaxa has the highest level of renal elimination, and also that apixaban or Eliquis have the lowest renal elimination of about 25%. Based upon the pivotal trials where these drugs were given indication, it has been possible to do some sub-analysis in patients with CKD stage 3 and 4. And this is because in these trials, patients were included down to an eGFR of approximately 25 mils per minute. So restricting these studies to patients with CKD stage 3 and 4, you could see that the effect of these drugs in comparison with warfarin was approximately similar to what was seen in the trial for the other patients with a normal kidney function. And this was also particularly interesting. This effect was the decreased effect of hemorrhagic stroke, because these drugs specifically reduced the risk of the adverse events in the patients more actually than they would decrease the risk of ischemic stroke. So the benefit of these drugs is a better safety profile. And this better safety profile was also evident in patients with stage 3 and 4 CKD. In response to these drugs, and when these drugs were registered, EMA and FDA, they actually had different views. And the European Medical Agency, they approved the drugs down to an eGFR of 15 mils per minute. And then dabigatran, because of their higher renal elimination, is not supposed to be used in patients with an eGFR less than 30. And the other drugs with a reduced dose less than 30 down to an eGFR of 15. In the US, the FDA, instead, they approved the use of apixaban in the normal dose of 5 milligrams twice daily, based upon pharmacokinetic evidence in hemodialysis patients, actually very few hemodialysis patients. And this led to a rapid increase in the use of apixaban in dialysis patients in the US after 2014. So when you meet the patients with CKD stage 5, where there is limited evidence, there are two questions that I need to ask myself. And first of all is, should these patients at all be treated with anticoagulation? And the second question is, which type of anticoagulation treatment is better? So if we start with then the second question, which is a question that has been investigated in some small randomized trials. We can start with the observational evidence based upon data from the US, where these drugs actually were approved. So this is a well-designed observational study in CKD stage 4 to 5 patients. And in this study, you could see that as compared to warfarin, the DOACs resulted in a lower risk of major bleedings, but a similar risk of ischemic stroke. But I have to remind you in that also in this cohort, also patients with CKD stage 4 were included. And patients with stage 4 actually were also included in the pivotal trials down to an eGFR 25. And you can see that this was actually similar to what was seen then in the sub-analysis from the trials. When it comes to dialysis patients, there has been some randomized trials, and the first that was published was the Renal AF trial. This is a trial that was performed in the United States, and this trial compared a standard dose of apixaban of 5 milligrams twice daily compared to warfarin with an INR target of in between 2 and 3. And this study recruited 150 patients, and it was stopped early because of recruitment problems. This trial actually saw no difference in the safety profile between these two treatments, but as you can see, the absolute rates of events in the apixaban arm was actually slightly higher, and this was a safety study. So it cannot really say anything about the efficacy of these drugs. But some evidence that actually was made possible after this trial was that a normal dose of apixaban actually resulted in higher therapeutic concentrations among these patients, which could have been partly responsible for their higher risk of bleeding in this trial. And another possibility of their higher risk was that a large proportion of the patients treated with apixaban also were treated with aspirin. So they had a combination treatment, and that has also been something that has been sort of discussed as what resulted in the higher bleeding risk in these patients. So then next came this European study. This is a study performed in Germany, and it's called Axadia AFNet trial. And in this trial, they used a lower dose of apixaban, 2.5 milligram twice daily, and it was compared to a vitamin K antagonist with an INR target of between 2 and 3. And as you can see from these results, there was no difference in the safety profile of this lower dose of apixaban as compared to warfarin. And also this trial was also very small. It included about 90 patients. And so you cannot say anything here also about the efficacy of the treatment. But you could also see that this lower dose of apixaban resulted in approximately therapeutic concentrations comparable to what has been seen in patients with a normal dose, which were not on dialysis. I also need to mention this third trial that has been published, and this is actually the Valkyrie trial. It did not have stroke as the primary event. And this trial was actually a positive trial. It saw a lower risk of cardiovascular events, which was the primary outcome for patients randomized to rivaroxaban as compared to vitamin K antagonists. And this trial also investigated ischemic stroke, but this trial included 150 patients, and it was not an efficacy trial for stroke prophylaxis, but these events also were kind of similarly distributed in between these treatment arms. And last of all, recently came the SAFE-D trial, and this was a feasibility trial conducted in Australia and Canada. The primary outcome here was actually recruitment rate and the possibility to recruit patients for a larger trial. And they successfully recruited 150 patients. And you can see from this slide that 83% of the participants completed the follow-up within their allocated treatment group. And this trial was the only trial that included a non-treatment arm in the trial. And this actually leads me up to the next question, and that is whether a patient in CKD stage 5 at all should be treated with oral anticoagulation. So we have to remember that there are actually no trials, including patients with no placebo-controlled trials in this in patients with an eGFR or GFR below 15 or 20. So you can actually say that the evidence for treating patients for efficacy ends around 25 mils per minute. And we cannot know anything about what happens in efficacy below that limit. There are some observational data, and I cannot show you all the data because there have been numerous observational cohort studies. This is a network meta-analysis where they compared all types of oral anticoagulation against anticoagulation. Or against no anticoagulation. And you can see here that for CKD stage 3, there is a clear benefit of treating patients with oral anticoagulation, but for CKD stage 5, there is absolutely no effect in treating patients with anticoagulation drugs. But on the other hand, these patients experience severe side effects. They have a higher incidence of bleeding events if you treat patients with anticoagulation, and there is no difference in all-cause mortality. There have also been some newer observational studies comparing vitamin K antagonists. And here I have to point out that these observational studies are in the complete opposite directions. So we have a Swedish study showing that patients treated with warfarin have a lower risk of ischemic stroke. And you have this American study showing that patients treated with anticoagulation have a higher risk of cerebrovascular accidents. So it all depends on study design and which treatment groups you include in your observational data, I would say. There has also been one well-designed observational study looking into the risk of treatment with DOAC in patients with a newly diagnosed atrial fibrillation, and this study is also then from the US. So they looked into patients who were given treatment with apixaban after incident atrial fibrillation diagnosis in the registry. And you can see here that patients who were treated with a normal dose of apixaban actually had a higher risk of any stroke or systemic embolism, and that patients who were treated with a lower dose of apixaban, they had similar risk of stroke as compared to patients not treated with any anticoagulation. And how does it come? Well, the patients treated with a normal dose of apixaban, they actually had a higher risk of fatal and intracranial bleeding, and this represents sort of the net clinical benefit of the previous slide that I just showed you. So this patient had a higher risk of intracranial bleeding, which causes, of course, the higher stroke incidence. And the patients treated with a lower dose of apixaban, they also had a slightly higher risk of intracranial bleeding, although this was not statistically significantly higher. So this leads up to our trial that we are now conducting with the Karolinska Hospital as the sponsor. And this study is the stroke prophylaxis with apixaban in patients with atrial fibrillation and CKD stage 5. It's called SAC trial. And the objectives of the SAC trial is to study both the efficacy and the safety of oral anticoagulation for stroke prophylaxis in patients with atrial fibrillation and CKD stage 5. And the hypothesis is that compared to no oral anticoagulation, apixaban reduces the risk of ischemic stroke and systemic embolism without causing an unacceptable increase in fatal or intracranial bleedings. And this is the protocol was approved, the latest version in 2024. And this is the study schedule. We are aiming to include about 500 to 700 patients in each treatment arm. And patients are randomized equally to either standard of care with apixaban in a low dose or standard of care with no oral anticoagulation. The study included its first patients the 17th of February in 2023, and we plan to have the last patient in the trial by the last of December 2027, and the results to be ready by the 31st of December 2028. The inclusion criteria in SAC are very simple. We should have an informed consent. The patients should be adult, and they should have an ongoing treatment with any chronic dialysis, which means that they could have either peritoneal dialysis or hemodialysis, or they should have a CKD stage 5 non-dialysis. And this means the patient with CKD stage 5 with less than 20 in eGFR 3 months apart the last year, with at least one occasion below 15. They should have a diagnosis of atrial fibrillation, and they should have an indication for oral anticoagulation with CHA2DS2-VASc score above 3 for women or above or equal to 2 for men. And they should not be of childbearing potential if they are women. The primary efficacy and safety endpoints are the primary efficacy endpoint is ischemic stroke or systemic embolism. And this event is adjudicated by at least 2 external reviewers. If they disagree, we have a third reviewer who designed the event. The first safety endpoint is the occurrence of a first intracranial bleeding or a fatal bleeding, which includes hemorrhagic stroke. And these events are also adjudicated by an external independent adjudication committee. We have also a number of secondary endpoints which are not to be adjudicated, and these are cardiovascular endpoints, cardiovascular event or cardiovascular death. We have all-cause mortality. We have thromboembolic events, including pulmonary embolism, venous thrombosis, and dialysis vascular access thrombosis. We also have a sort of net clinical benefit outcome, including all-cause strokes, systemic embolism, and intracranial bleedings. We also have clinically relevant major bleedings according to the ISTH definition, and minor bleedings also according to their definitions, but adapted to dialysis patients. In this study, we also have a sub-study including patients on the waiting list for a kidney transplantation, because this is a major issue in patients waiting for a donated kidney. So patients who are being transplanted at Karolinska, Uppsala, Sahlgrenska, and Helsingfors in Sweden and Finland, they could also be part of the trial, because these transplantation units, they use a special protocol for these patients to reverse the effects of patients treated with apixaban. And then we will investigate if patients are affected by more surgical bleedings, delayed graft functions, or renal, arterial, or venous thrombosis. So this is the last slide. It just presents our overall achievements to this date. And we started a study in Sweden, Norway, Finland, and Iceland. And this summer, also Poland joined the study. We have approval for starting the study in the Netherlands, and we are currently seeking CITES application, the ongoing process, also to include France as a part of the study. And as of yesterday, we had included 412 patients in this study, and this is approximately 40% of the target of 1,000 patients. So thank you very much for letting me present this data.
Thank you very much for this great presentation. And yeah, some question I had before you answered in your presentation, like how is the recruitment status? You said yesterday 400 patients. I think that's a great result. So how can you motivate your patients to be part of this study? Because I think that's a big problem. We all know our dialysis patients, they take a lot of medication. They are often in hospital. They don't want a new appointment and another pill or something like this. Yeah, how you motivate your patients and how many percent decline to take part in the study.
Yeah, I mean, these are crucial issues to all investigators in trials. I mean, how do you motivate patients? And I think that actually patients are not that difficult to motivate. Approximately 50% of the patients, I think, overall decide to participate. And I think some sites even have higher participation rates. But it is a difficult trial to explain to the patients. Because what my patients tell me is that, well, now you're telling me that I'm either going to have a stroke or I'm going to have a bleeding. So what am I? Why should I do this? You just I'm just terrified now. So what we are trying to say to them is that hopefully they will not experience any of these events, and we are just very, very clear to the patients about the evidence. Because this is the only way we can motivate patients, is to just tell them that actually we don't know what is best. So you are actually helping me in my future decisions, and it may not benefit you, this trial, but it will certainly benefit all future patients experiencing atrial fibrillation and on dialysis. And I think patients are not stupid; they understand these things. And many patients tell me that they really want to participate because they want to contribute to increasing the knowledge. But there are other things, and then we have made the study very, very pragmatic. We have tried to reduce the burden for both centers and for patients. So we have the screening takes part before the patients even enter the trial. There are no sort of requirements of any. You don't need to do an ECG when they are included. You don't need to. So it actually just requires a clinical diagnosis. You look into the history of the eGFR or the dialysis and exclusion criteria, and you can base your sort of screening based upon this information. And then there is a visit when you both screen the patient and you include the patient at the same visit. And then we only follow the patient through reviewing the medical record and telephone calls to the patients with every first of 3 months and then every 6 months.
And another question I have. So we see the inclusion criteria. Patients are active on the kidney transplant waiting list, and they are excluded if the transplantation center don't allow Apixaban or a DOAC. So that's a problem we also see in Germany. Not every transplantation center is happy with DOAC or Apixaban. So what do the most transplantation centers prefer in Sweden?
I mean, before this study, the transplantation clinics they said that, well, in my sort of personal communication with them, they told me that they were positive, but they didn't know, and they felt insecure because there was no protocol. But they were actually positive, and I think that they would like to collect evidence that it's safe, because also we know that warfarin, these patients could be treated with warfarin or vitamin K antagonists, and this is not very secure either. And they are already reversing these patients. So then we developed the protocol together with the hematologists and the anticoagulation experts. And they are now reversing patients with the prothrombin complex. But it is only transplantation centers who approve this, who take part in this part of the study. And in Sweden and in Finland, patients are registered at a specific transplantation center. So patients who are, for example, in Norway, they were more unsecure and they did not approve this, the use of Apixaban in patients on the waiting list. So they do not allow patients on waiting list to participate in the trial in Norway.
How many transplantation centers do you have in Sweden? So you told us 4 centers will participate, 2 of which are in Sweden, 2 of which are in Finland. I think
Yeah,
Sweden has
so
about 10
yeah,
million inhabitants.
yeah, we have 10 million people and 4 transplantation centers, and we have 3 transplantation centers participating in this sub-study. And there's only 1 transplantation center in Finland, and it is participating.
But this protocol that you use does not include andernexonet, but you go for coagulation factors because, to my best understanding, andernexonet is prohibitively expensive and there's not really good experience with this in CKD. You go with coagulation
No,
factors.
exactly. And also, it's not currently, first of all, it's very, very expensive. And secondly, it is currently not recommended. We have sort of a central committee in Sweden for all types of newer drugs. And this treatment was not recommended, if I am correct. At least it was not when we registered the trial. And also, many of the surgeons are used to using a prothrombin complex for for acute bleedings in patients on apixaban, so they were not unfamiliar with this.
So my last question, another exclusion criteria was or is when the patient is on dual antiplatelet therapy. So usually I think apixaban and aspirin, for example, is allowed. So for the moment, do you know how much patients are on apixaban and aspirin in your study?
Oh, I should have looked this up. I have the data, but actually I can't remember it. But we do recommend patients who are randomized to apixaban. It's said in the protocol that we recommend them to discontinue the aspirin. And we have also in the steering committee, we do have involved cardiologists, and they tell me that there are very few circumstances when it's actually indicated with a dual therapy of apixaban and aspirin. So this use should be tried to be restricted.
And we have discussed this some weeks ago. There are great studies from France, the aquatic study, even in people with normal kidney function. It's no good idea to combine these two.
Mm.
I have 2 remaining questions on the study protocol before we have a couple of other questions beyond SEC. So the first would be, I hope I didn't miss it. You have these 2 primary endpoints, safety and efficacy. They are both at the same level, so you will test them both as a 0.05, I guess. And do you test for? No. Okay.
No,
Yeah.
no, actually we are not. So initially this was actually some sort of a lot of discussion. So currently, so we have one primary endpoint, and that's the efficacy endpoints. And then the safety endpoint is actually described as the first secondary endpoint, safety endpoint, and we do not we not test for it because we assume that the bleeding rate will be higher. I mean, if you compare anticoagulation treatment to no treatment, then it will be higher. It's just a matter of how much higher. So what we are interested in is the absolute rate. And we sort of test this in the, so we look at the absolute rates, and then we assess the net clinical benefits in this secondary endpoint as well.
And you test for non-inferiority primarily, not for superiority, because you would expect that there's no increase in ischemic events, wouldn't you?
We test for the superiority for the treatment.
Okay. And one other issue, I think it's great that you also include people who are not yet on dialysis. If I got it right, you start once the GFR falls below 20, given that at least one measurement is below 15, but you go for GFR, you don't go for creatinine clearance, because this creatinine clearance makes it difficult for us in clinical practice because nobody's used to check the creatinine clearance. Everybody looks at the eGFR, but surely we should go for creatinine clearance. So why did you choose the more convenient way for us?
think that, I mean, we use the eGFR because that's how we think it works. And you could actually calculate, mean creatinine clearance, if you mean like the absolute eGFR, it could be calculated, but we're more pragmatic. We use the eGFR value, but we say also that, I mean, we acknowledge that these are all estimates, and it could be like the probability of the eGFR to sort of reflect the true GFR. We don't really know because we don't measure GFR. And we say that we could use any equation to estimate this GFR. It could be from cystatin, it could be from chrome EDTA, or it could be measured GFR. Or it could be by MDRD equation or CKD-epi, or the equation that you feel is best fits this patient. And this is also another pragmatic solution to sort of reduce the problems, to reduce the burden for investigators, and also because I think there are so many error sources for eGFR, so those probably matter more than if you measure the creatinine clearance or the eGFR.
I actually have one more question on the study design. Sorry. There surely is kind of a risk that people who are randomized not to receive apixaban, that they might be more likely to receive aspirin compared to the arm where you would have aspirin as apixaban, as the standard. But surely that cannot be controlled for, I guess, and that's then part of the study design, isn't it?
Yeah, yes, also, and also because we are allowing patients to discontinue warfarin, for example. So if you include a patient who was previously on warfarin, that patient could actually have an indication for aspirin because that patient could have ischemic heart disease. So in that case, it would be wrong not to prescribe aspirin. So there will likely be a higher incidence of aspirin in the sort of in the non-anticoagulation group. And we will compare the intention to treat. And this will be something that will likely be cause discussion afterwards when we have the results. But I think it's very interesting because who knows? I mean, it could be also reducing the risk, but that will only make the difference smaller between the groups.
Yeah. And since you plan to go to France, and since we have a couple of French colleagues who are following us, if they would like to participate, then they can contact Anne-Laure, I guess, and you will be the bridge to France, won't you?
Maybe Anne-Laure, maybe you would like to say something about, because Anne-Laure is now working hard to include France in the application. Maybe you would like to say something to your French colleagues.
Yes, absolutely. I mean, thank you very much, Marie, for this amazing presentation again. Yes, as Marie said, that due to the strong scientific interest generated by the SAC study, several sites across Europe has been opened, and I can't remember if you said that we have now like 40 centers in 6 countries in the European Union, and now we are about to open 3 centers in France. So yeah, we are very, very happy with this. And if you would like to participate to this study, don't hesitate to contact me or Marie. We will be happy to help you to gather all the documents for the CETIS application. Yeah.
Are you already allowed to disclose which centers in France will participate, or is it still under embargo?
I don't know. What do you think, Mary?
No, we are open. I think since we are applying.
So the 3 centers are Paris, Lyon, and the western region of France, like Pays de la Loire. Yeah.
So actually everybody can come to one of these centers. And I'm aware that in Normandy, they do have a separate study for PD patients, which we discussed in last summer. But this is the comparison then between DOACs versus vitamin K antagonists, which are in France, I guess, not fait pour comment as in Germany, but warfarin like in Scandinavia and other parts of the world. So
Yes, we
maybe,
are thrilled
sorry,
to include France. Yeah.
so maybe some general questions then in the end. How do you see the future? So we have been discussing for quite a lot of years, the option to go for vitamin K antagonists or DOACs. Now we come back to the question, should we go for anticoagulation at all? We had two ideas that looked very bright in the not too far past, which have lost some of their attractivity in the last months because we saw a couple of studies that were rather disappointing. Surely I think of the factor 11 inhibitors and the left atrial appendage occluders. Looking now into 2026, 2027, do you expect game changers to come from these approaches, or have we had hopes that have been too high?
Oh, that's a very, very difficult question, I think. I think the issue with anticoagulation is extremely difficult in patients with CKD stage 5. And actually, after 2 years or 3 years in the SAC trial, I think it is even more challenging because now, I mean, I am the PI of this also for my site, and I see many sort of side effects, not many side effects, but I see side effects. And we do have to acknowledge that these patients have a very high incidence of all types of adverse events. And even in patients who are not treated with anticoagulation, there is a high risk of bleeding. But I think that what I see from now on is actually that more and more centers in Europe are starting to use the DOACs, whether there are evidence or not. So this is a trend that I'm seeing, and I do not know currently if it's good or bad, but I think that at least. I mean, we think that we do good, and there are some signals that DOACs actually reduce the risk of bleeding compared to vitamin K antagonists. And as we know that there are so many other sort of drawbacks with the vitamin K antagonists, I should say that if you are at all thinking of a patient or treating patients and you cannot participate in a trial, I think that the DOACs is probably a better choice if you compare the two of them. That I can say.
And there are a couple of other studies going on at the same moment. Another trial from Scandinavia, DOAC. There has been one trial in France, which to our best understanding has been stopped because it was quite hard to recruit patients into this study. Then to our best understanding, there's one study ongoing in Brazil. So is there any communication between the different studies? Are you cooperating on a Scandinavian level to have these two trials then in the future in one meta-analysis?
Yes, we are. I mean, we are communicating. I mean, in the way that the downward study had already started when we planned SAC study. And unfortunately, it was our neighboring country, which we would have loved to also take part in SAC. But now we are eagerly awaiting both results, and when these studies have been completed, we are planning to do some meta-analysis. But it will take a few years before we are there.
So for the end, I have, I think, a big question for our clinical colleagues. So you do risk stratification in the study with the CHEST-WASC score. We all know you have more or less points, and above a level, we should do anticoagulation. But we see in the last years, I think if you have a dialysis or CKD patient with atrial fibrillation, most patients have a high CHEST-WASC score, and most patients need anticoagulation when we think of the CHEST-WASC score. There are some new risk scores like dialysis risk score, who use less comorbidities or less risks. So what would you prefer or what would you say that's a good risk stratification tool for the clinical colleagues?
Yes, evidently Schwarzbach is poor in predicting stroke events. It is actually only little bit better than chance to predict risk, and it actually underestimates the risk of stroke in patients. But also, the Hasbled score is very difficult to use because it's not. It also predicts poorly in our dialysis patients. So I think that the new risk scores are probably better than the old ones, but we still need to be aware of that it is very, very difficult to use any risk score. And when I personally think that your own clinical judgment is probably better because there are so many aspects that you cannot weigh into a risk score. So unless you really know that, I mean, you have a risk score that is not totally validated, and you have a treatment that is certainly non-evidence based. So then you are sort of ending up anyway in the in some in some area where you really don't know what you are doing. So overall, I would rather go to my clinical judgment and look at the patient, and also discuss with the patient what the patient really thinks is worst, because many patients have their own opinions on what do they think. If they're really, really afraid of having a stroke, maybe they would like to have some anticoagulation, if there is if you think it's reasonable. And also there are patients who really do not want to take any more drugs. So then maybe you could consider not to treat them.
And surely we have to include these people into the studies. In Scandinavia, surely in your study, in France, in your study, in Germany, we have the study from Ingo Eitel on the occluder. I have one final question, that just came to my mind. So you showed us the comparison between the train and the BMW. I was just eager to learn from you. So was this for the German audience? Do you also show the BMW when you go to Scandinavia, other countries, or do we switch to the Volvo or whatsoever?
Well, Anne-Laure actually told me to switch from a Tesla, and I thought it was a very good advice. So she suggested a Volvo, but then I thought, well, Volvo is owned by a Chinese company, so I wouldn't.
No,
I wouldn't use that.
as I suggested Porsche, but
yes,
you chose
BMW was perfect because Caroline actually comes from Bavaria, so it's a home run for her.
Yes, it was the best choice.
So yes, thank you again for joining us again by Marcus at Home. It was a pleasure to meet you again, and I think we can look forward for a new meeting in future, maybe when the sex study is completed and the results are available. And I hope we see you next time.
Thanks a lot.